Nobody ready fast enough?
Okay, Gabby, please line your stomach for me. And just place this on your waist. Place your head in there. Okay. Okay, so first we're going to start with sacral extension, also known as sacral backwards bending, also known as counter nutation. Okay, so the sacral extension plays an important role with other movements such as internal rotation of the ilium and internal rotation of the hip joint, typically with internal rotation of the ilium and also internal rotation of the hip. Typically the sacrum backward bends, or we call extension. All right, so I can assess sacral extension and also treat it with mobilization. So what I'm going to do is come around. I'm going to place my thenar, hypothenar eminences around S3, S4-ish, 4-ish, and somewhere in that area. So around S3, S4, and I'm going to apply a PA. On the plant so I can drop my body weight, use my body weight. So typically what I do, especially with females, I make sure I don't lie my hand flat down. I always have my fingers pointed up towards the ceiling and utilizing my hypothenar and thenar, hypothenar and thenar eminences. And this is a technique, so I will show them the technique in the book. So I typically show them in the book. You can use your slides to show them, like, this is where my hand placement will be. And that's why I have it done with the skeleton as well, so the patients will know that you're actually doing a technique. So I come here like so, and I assess. Any pain or discomfort with that, Gabby?
Nope.
Okay. So her sacrum is moving to extension, got a little glute contraction there. Sometimes that's normal, sometimes that happens. Or I can utilize my hypothenar eminence like so and go perpendicular to the sacrum. So right now I'm parallel with the sacrum with this contact, and I can go perpendicular to the sacrum again. Now my other border of the hand is in contact around S3 and S4, and the remainder of my hand is slanted up towards the ceiling. I apply a PA, and I'm getting a sense, again, when I perform joint mobilizations, I'm always getting a feel for the motion of whether it's aberrant or smooth. That was smooth. Whether it's hyper or hypomobile, I try to get a sense of that. So that probably seems like her normal. It was neither hyper or hypo compared to others I have assessed as well. Okay, but that is sacral extension. All right, so what are those other component motions? Not component motions, but coupled motions, we would say, where sacral extension is required.
Backwards bending.
So that's where I ask questions for clarification. So sacral backward bending is synonymous with sacral extension, also synonymous with counter nutation. The coupled movements are iliac and hip internal rotation. Okay, so when I internally rotate like this, my sacrum is extending, it's backwards bending, it's counter nutating. Okay. All right, when I externally rotate, or even when I flex the hip, right, or either when I squat, my ilium are rotating posteriorly as my sacrum is nutating or forward bending, all right, or flexing. Okay, so now I'm just gonna keep going. So that's the technique for sacral extension. Now we're gonna go into flexion. And you all have all the write-ups. You can go back and read the write-ups for that. So flexion, so you can see how my hypothenar and thenar eminences are located on the base of the sacrum using the skeleton. So same thing, like so. So we'll come to the base of the sacrum, like so. And I'm just gonna use one hand. Okay. I heard a little release. Was that you? Huh? Did I hear a little release?
A little bit.
Mm-hmm. I heard like a little audible pop. So right now, I'm doing a PA, posterior to anterior foot of the base of the sacrum, and it's moving it into a forward bending. So it's forward bending, flexing, or what else did I say? It's nutation. Okay. So as I flex, so say I do a squat. As I do a squat and flex at the hip, my ilium are posteriorly rotating relative to the sacrum. The sacrum is nutating. As I come back into extension, the ilium are anteriorly rotating, right? So they're rotating anteriorly, and then the sacrum is extending. It's counter-nutating. All right, so that's those two. I can also, what did I do on that picture? Okay, I also did like this hand placement like so. And this is the hand that is providing the PA and moving the sacrum into forward bending, like so. And you have to work through the skin to get to the osseous structure, then mobilize the osseous structure. All right. Now, what am I gonna do? Let's skip. I'm gonna skip. Let's see if I put these techniques on here. Yes, I did. So I'm gonna skip. And the reason why I'm skipping is because I'm gonna go ahead and show the techniques that I do a lot in the clinic. So, what do we say? We said that when the ilium and hips internally rotate, what does the sacrum do? It does what? Extension, right? So I can combine those. So if I feel that's something that I need to improve on whatever side, so say her right side is limited with hip internal rotation, the ilium is not internally rotating, I can combine the movements and say I distinguish and determine that she's limited with sacrum back bending. I can come here and time this, and as and so I'm timing this with her breathing. So notice, what am I moving her hip into? Internal rotation. There we go. So I'm performing sacral extension and internal rotation of the hip and ilia simultaneously. So this is important to notate. As she inhales, so as she inhales, so if you stand up for a minute, stand up. So take a deep breath in. And take a deep breath out. So as you take a deep breath in, as you inhale, what do you feel your sacrum doing? Inhale, take a deep breath in. Then exhale. So kind of feel what your sacrum is doing. So when you inhale, the base of your sacrum, see if you can feel this. The base of your sacrum should move posteriorly. It should extend. Then when you relax it and exhale, you feel it go down back into forward bending. That's what you should be feeling. All right. So when I'm timing this, so I think Gabby probably should have felt me timing it. So she's relaxing, she's going back to forward bending as she exhales. Now when she inhales, that's when I apply my force and perform internal rotation at the same time. Now I can go back. Now I can perform forward bending along with external rotation. Now what's going to facilitate this, when she exhales, I come back. And I'm timing it with her exhale. You see? And I can go further. You feel that, Gabby? So I was timing it. So when she exhaled, she automatically went into more forward bending. The base of the sacrum went forward as she exhaled. All right? And so the exhale facilitated the forward bending and external rotation simultaneously. Okay. All right. Now, it could be that when you get a patient, when they have low back problems, hip problems, don't forget to assess the SI joint. And so you can assess the SI joint by assessing forward bending and backward bending. And you can also assess hip and iliac internal and external rotation as well, because those will be problems that we miss. Sometimes patients don't know how to explain SI joint dysfunction. They just say it's low back pain, you see. And so many times when we entry-level therapists, like myself, entry-level, you know, I may not have gone down and looked at the SI joint like I should have. Then I got more training, more education. Then I knew, okay, man, I gotta be looking at this SI joint. But see, you all are gonna have a heads up because you're getting trained on it now, okay? So those are 4 techniques we're gonna let you all practice. Practice the forward bending of the sacrum, backward bending of the sacrum, assessing, and then mobilizing, and then practice the hip iliac internal rotation with sacral extension, and practice a hip iliac external rotation with forward bending. All right, sacral rotation mobilization. Okay, I'm just gonna stand on this side. All right, so this is what I am going to do. All right, so my left hand is going to be on her right sacral base. And so what I want to do is improve rotation to the left. See? She's going to rotate, her sacrum is going to rotate to the left. So I'm going to impart my PA through the right sacral base. All right? When I impart my PA through the right sacral base, so imagine this being my sacral base and this being the right side. When I impart my PA, it's going to do this. So it's going to rotate to the left. Everybody see that? So I'm going to come here and get my contact using my hypothenar eminence on the right sacral base, and I can come and contact her ilium anteriorly, okay? And again, I'm doing a respiratory assist with exhalation. Okay. So as she exhaled, I imparted my PA through the right side of the sacral base. All right, and that produced a rotation to the left of the sacrum base. So I used the hypothenar eminence of my left hand. Now with this right hand around her ilium, I can either stabilize here, or I can provide a little force towards the ceiling, or force towards the ceiling, or an external rotation force of the ilium on the opposite side. So that's that technique. I can also do it to the opposite side. So I can go to the opposite side, right? Right hypothenar eminence on the left side of the sacral base. When I provide the PA there, what is that going to produce? Rotation to the west side, to the right side. And I can bring my hand right here around the anterior aspect of the ilium. I can stabilize there. Or if I want to, just provide a force towards the ceiling if I wish. All right. And again, using a respiratory assist with that as well. So.
Remember, you name rotation for which way the anterior surface of the sacrum is facing. So a lot of times I have to beat the sacrum, right? So if I'm the sacrum and you push it, this is the back of the sacrum, Dr. Carter mobilized the left sacral base forward. It's right rotation. Sometimes even in the clinic.
I forgot a piece too. Let me go back. So I'm gonna put this hip. So say if I wanna improve rotation to the left to facilitate the technique even more, I'm gonna put this hip in external rotation. All right, I'm gonna put it in external rotation. Then I'm gonna put this one in internal rotation. Then come back. Right here, again, hypothenar eminence on the right side of the sacral base to produce left rotation. Come around here, right ilium, more so this hand right here is just stabilizing and providing my PA. Using this hand to stabilize around the ilium and trying to contact the ASIS. So don't forget to facilitate that. And put the hip that you're mobilizing put the side that you're mobilizing into rotation, put that into external rotation to facilitate the forward bend on that side. Because remember, when I externally rotate this hip and ilium, that's going to facilitate forward bending on that side, since that's a coupled motion. All right, got that? All right, go ahead and practice that one. And Dr. Claire and I'll be walking. Okay, Gabby, we're ready for you. So Gabby, your right foot is gonna be fixed on the floor. You're gonna lie down like this. If you can, I'll raise the plinth up if you need to raise the plinth up. So just like in the picture. You can do it on that side, that's fine. You can do it on that side. You go to that side. You go to that side. It doesn't matter.
I might need to brace a little bit.
One leg will be up there, right?
Oh, his legs will be up.
Yes, that leg will be higher up. There you go. Yes.
Okay. So you need to raise you up some more?
A little bit. There we go.
All right. So this is a technique that I show my patients so they'll know where I be in proximity to them when doing this technique, so that they'll be aware of that. Because in a sense, I'm gonna kind of be like in between both legs, so it's good for the patients to know where you're gonna be with this technique. So this technique is gonna be mobilizing the ilia anteriorly and rotating the ilia anteriorly. And so in this case, we're on her right side. So this is her right leg is on the table, her left leg foot is fixed on the ground, and I'm gonna basically just come up right here like so. So what I'm gonna do, so that my body doesn't contact her in an inappropriate manner, I come and place my legs almost against the plinth, like how you see in the picture. So I kind of place my legs against the plinth, and I take my left hand, in this case, and put it on the posterior aspect of her ilium. So I capture the posterior aspect of her ilium, and I'm gonna take her leg, right? Okay. And as I apply a PA through her posterior aspect of the ilium, I'm gonna lift her leg into extension. And so this helps to improve. Now, I assessed that there's something going on here. I don't know what it is. It's some aberrant motion. All right. I felt something, it just wasn't smooth. I didn't hear any clunking, but it was some aberrant motion. Would you agree? So I had to investigate that further. So I performed it some more. So now this may lead me to going to assess her hip joint. All right. It could be that I'm just introducing the technique, and performing it more may resolve things. So now I don't feel that, there it went, there it goes. Okay, so that's the technique. All right, you can come out of that position, yeah, because that position can be uncomfortable for some patients. So, but that's the technique for anterior rotation of the ilium. All right, now, let's see. All right, I'm gonna assess the same extremity. So that was the right. So you're gonna lie on your left side. So since I felt some aberrant motion, it wasn't a smooth motion, and I think that aberrant motion occurred at the articulation of her femur and acetabulum. I'm not for sure though, but I think that's why I felt the aberrant motion occurred, not specifically with her ilium movement. Okay, so now this is posterior iliac rotation mobilization. So now one of my hands, which is going to be, in this case, come up. In this case, it's going to be my left hand. And my right hand is going to contact the anterior superior iliac spine. All right? And scoop towards the edge for me. There we go. Again, this is a technique that I would show my patient beforehand. Well, especially where my hand contacts are going to be and where I'm going to be in proximity to the patient. Now with this technique, I may use my body to help. I may use my thigh to help me facilitate more flexion at the hip. So I'm going to come in like so. Get in right here. This hand's on the ischial tuberosity. And what I'm going to do is I got a force with my right hand going this way, and then I have a force with my left hand coming up this way. So almost in a sense, moving like a clock. Now, so You say, Dr. Carter, why did you want to do the same side? So first of all, I want to compare I want to compare anterior iliac rotation to posterior iliac rotation. So in comparison, posterior iliac rotation was smooth. No aberrancy. I didn't feel any hypomobility. So nothing specifically restricted me from getting her to the end range with that. Now, this technique, based on my hand placement, was more specific to moving the ilium. The other technique, if I lift her hip, it incorporates some GH joint as well, right? So now,
Not GH.
I'm sorry, for more acetabulum hip joint. I'm glad y'all caught me on that. All right. See, so her femur and acetabulum articulation becomes more involved with the latter technique of assessing anterior iliac because I'm moving the hip into extension. So that's where I felt something funky, and I think Dominique saw it as well. You can see something going on at that for more acetabular articulation. So then I would step away and probably come back and reassess that separately. Okay, so those are two techniques you can practice, and Dr. McClure and I will be coming around. All right, Gabby, you gonna lie down on your stomach for me? We're gonna come in frog leg over here. All right. Okay, the next and last technique that we're gonna do to wrap up the SI joint assessment and mobilization interventions is the SI joint distraction mobilization. This is a beneficial technique for someone who's inflamed at the SI joint or they have pain at the SI joint. We know we can do grade 1, grade 2 distractions to help relieve pain at the SI joint and also to improve mobility at the SI joint as well. This is a good starting technique before doing the other techniques. So you can always start off with your SI joint distraction technique to see how patients who may have SI joint dysfunction respond to this technique. But this is a very simple technique. So you get the patient lying on the plinth, the joint, the side of the SI joint that you're gonna mobilize, you're gonna put that leg in like a frog leg position. So scoot over towards the edge of the plinth. I kind of want this leg to hang off, come over a little bit more. Okay, great. So I'm going to utilize my hand to come around the medial aspect of the distal femur. I'm going to kind of hook around. And so I'm going to lift your leg up, kind of see that in the video. So I'm kind of I'm hooked around her femur like so. And now I'm going to take my right hand and put it on the PSIS of the ilium. And I'm going to apply a distraction with my left hand as I apply the distraction through my right arm in an inferior lateral direction, like so, on the PSIS. So I'm distracting. You feel that? So I'm timing it. I'm doing the distraction. I'm doing the force with my right hand and the pulling force with my left hand. I'm doing those simultaneously to generate a distraction, and this would be a distraction of the left SI joint on the left side, and I'm moving the ilium away from the sacrum, right? So I'm moving the ilium away from the sacrum. Show you one more time. like so. All right. All right, you can sit up. Let me see if I can show it on the scale, so on the trolley. So right here, right here, this hand coming down, providing a force, and I'm doing so like so. So going down and out. So you can see when I do that, this is going to distract and move away from the sacrum.
So for the other hand, you say you are kind of doing the inferior force with that hand?
Yeah.
Like pull
So
down.
I am pulling down with this hand like that. So trying to generate. So as I pull on the femur, it's gonna pull the ilium as well, because you got those ligaments and muscles attached that are gonna generate a force through the ilium as well.
So as long as your patient's got a stable hip, femorized tablet, it should be good. Don't take up tension and just encourage what you're doing.
So wet motion, can this improve at the SI joint? There you go. Good. Man, y'all learned a lot. I'm very proud of y'all. You display it too. Very good. You on point. All right. All right, go ahead and practice that. Dr. McClure and I'll be walking around, and then we'll wrap it up with a little quick Q&A.